along with Dr. Roosevelt Bryant, who's the surgical director of the transplant program, I believe. As a sideline to taking care of kids who need cardiac transplants, Dr. Ameduri has started a clinic treating kids in congestive heart failure, from which many of the transplant patients comes. But today she's going to talk to us about genetics and cardiomyopathy. Usually I come into contact with this when I see children who have a sibling or some other family member who has cardiomyopathy, and the question comes up about testing. So I'm really interested in hearing what you have to say, Becky. Thank you.
Thanks, John. Can you guys hear me okay? Is the microphone okay? All right. So as Dr. Bass said, I'm going to talk today about screening for genetic heart disease. And I think the one thing that is relevant to general pediatrics, the reason to talk about this, is how to detect these patients before they have a fatal event. I think that's what is covered in the media, and that's what we see a lot of. So how do we detect those patients before that happens? Briefly just review the learning objectives for today, to identify patients that are at risk for genetic heart disease, understand the basic screening and testing for cardiomyopathy, and hopefully give you a little bit of a sense of differentiating between the different types of cardiomyopathy that we see. In order to kind of get to those objectives, I'm going to talk a little bit about the background of why are we talking about this, give you some background information, present a case, and then we'll talk about the different types of cardiomyopathy in a little bit more detail, and then kind of wrap up at the end with some recommendations. So why do we need to screen for genetic heart disease? When we see these cases, sudden cardiac death in athletes is uncommon, but when it happens, it's tragic, and it's splashed throughout the media. So it's what patients and referring providers and physicians are worried about. These high-profile cases highlight the need for screening for heart disease in athletes, and I think there's a lot of controversy about who should be screened, how should they be screened, and in what detail. So the true incidence is unknown. There's estimates anywhere between 1 in 23,000 and 1 in 300,000 athletes. There are multiple papers about this, and I'll present some of the data here. There's one that's a review of almost 1,900 deaths in young athletes from 1980 to 2006, and 1,000 of those were determined to be cardiac in origin. Those death rates for those years range between 50 and 76 per year. So we're not talking about a large number, but as I said, these are highlighted in the media, and these are what patients and families hear about. When we look at the population that's at risk, there are over 5 million high school athletes, 500,000 college athletes, and 5,000 professional athletes. And so these are people that are in highly competitive sports, but there are also people that aren't as competitive athletes that are also at risk. There was a more recent study looking at NCAA athletes from 2004 to 2008. In that, there was 273 deaths, with 45 being cardiac deaths, which gave an incidence that was much higher than that other general population incidence of 1 in 43,000 participants per year. And there are certain subgroups that are much higher. Division I male basketball players had a rate of 1 in 3,100. So these are, for some reason, a high-risk population. Presumably, these athletes underwent pre-participation screening, and the NCAA screening usually does include an EKG, which is one thing we'll talk about that's controversial a little bit later. The problem is there can be considerable overlap between the changes induced by intensive athletic training and those due to genetic cardiac disease. And I think the important thing for general pediatricians is to try and figure out, how do I differentiate those changes? How do I know who needs to go on to further screening? There was a paper published this year, actually, that looked at the incidence specifically here in Minnesota, so kind of closer to home information. This looked at forensic case records for U.S. National Registry of Sudden Death in Athletes. From 1986 to 2011, and there were 13 sudden deaths in high school athletes related to physical exertion, with an age range of 12 to 18 years, a median of 16 years. 7 of those were found to have a cardiac cause, which gave an incidence in Minnesota of 1 in 150,000 participants per year. So not as high as that NCAA paper, but still it's important. And what I would say is this is looking at those that actually, these are autopsy records or forensic case records, so these are ones that actually went to cardiac death. Some of these, and what's not encountered here is the aborted sudden cardiac death, so those patients that are resuscitated or that get through that event. When we look at the causes of sudden death, I'll present 2 slides here, but have similar breakdown. Hypertrophic cardiomyopathy being the most common cause of cardiac sudden death in young athletes. The other ones that we'll talk about, dilated cardiomyopathy represents about 2%, arrhythmogenic right ventricular cardiomyopathy about 4%, and myocarditis about 6%. There's some other much less common things where the screening questionnaires and the screening are maybe not as likely to pick up. Coronary artery anomalies I'm not going to talk about today, but that's one that maybe screening EKGs would be able to pick up. And then rhythm stuff I'm not going to talk about at all, so any of the channelopathies or long QT or those things, I'll leave that to Dr. Juraskar. This was another paper that looked at a smaller subset of those patients, but had a similar number or similar percentage for hypertrophic cardiomyopathy, also for myocarditis around 5 to 6%, ARVC 3%, and dilated cardiomyopathy about 2%. And then the other one on this is commotio cordis, which I don't think that they broke out in the other paper, but the baseball player that gets hit in the chest with a ball at high speeds that has commotio cordis. So that is not accounted for in that other paper. So how is the screening performed, or how do we screen athletes? The Lucene recommendations were created in 2004. There was a committee under the umbrella of the International Olympic Committee after a athlete who died after a trial event for the Olympics from a sudden cardiac death event. So the goal was to identify as accurately as possible athletes at risk in order to advise them accordingly. And with this, they recommended extensive personal and family history, a physical exam, and a 12-lead EKG. In 2007, the American Heart Association actually came out with guidelines. This included a 12-element medical and family history, as well as a physical exam, but did not recommend the 12-lead EKG. There is an Italian study that I think is frequently quoted that showed a 90% decline in sudden cardiac death in competitive athletes since they instituted EKG screening in 1982. However, that remains controversial because of high false positive rates and then resulting in unneeded testing for a high number of patients if we do EKG screening in everybody. This is the 12-element AHA recommendation for pre-participation cardiovascular screening for competitive athletes. This is, I guess, a frequent referral to cardiology, and I guess that's important for us to talk about today for the general pediatricians in the audience of what do these things mean, and positives on here, what is the next step. But looking at this, there's personal history questions, so if they've ever had exertional chest pain or discomfort, unexplained syncope or near syncope, excessive exertional and unexplained dyspnea or fatigue associated with exercise, prior recognition of a heart murmur that has not been evaluated, elevated systemic blood pressure, and then the family history components. If there's premature death, sudden and unexpected, or before the age of 50 due to heart disease, disability from heart disease in a close relative at an early age, so less than 50 years of age, or specific knowledge of certain cardiac conditions in family members, so things such as hypertrophic or dilated cardiomyopathy, long QT syndrome, Marfan syndrome, or other arrhythmia syndromes. And then on their physical exam, heart murmur, femoral pulses to exclude coarct, physical stigmata of Marfan syndrome, and then a blood pressure, an arm blood pressure. I think some of these are picked up on different pediatric practices use different pre-participation screening questionnaires, and I would say some of these are picked up on there. But also when you're seeing patients, it's important to ask the specific questions. The premature death question I think is a hard one that, unless you ask it in specific ways, or unless you specifically ask about family history of cardiomyopathy or heart transplant or heart failure, they may not give you that information. So I'm going to kind of flip gears a little bit and go through and talk about a case presentation of, why is this important to us. So we had a 17-year-old competitive basketball player who had no significant past medical history, who collapsed suddenly on the basketball court 5 minutes into the game. He had bystander CPR initiated. An AED was actually on site at this high school basketball game and was placed, but did not show a shockable rhythm. So CPR was continued. EMS arrived and again found that he was in a tachycardia, but it was not thought to be a shockable rhythm. And they attempted adenosine × 2 for a possible SVT. And he was taken to the ED for management. He was found to be in an atrial tachycardia that was a cardioverted to sinus rhythm, and was then managed with cooling for this post-arrest event. He had an echocardiogram performed as part of this initial workup that showed a dilated cardiomyopathy with an ejection fraction of 20%. And he was then transferred here for further management. When we see patients like this, we see a patient who acutely had an arrhythmic event and acutely has a decline in function. Presumably was healthy. Apparently he was a very competitive basketball player prior to this. We think of myocarditis kind of as the first thing, something that's going to acutely cause you to have a decline in function. And so he was worked up for a viral myocarditis. The most common viruses that we see listed here, but Coxsackie, adeno, influenza, RSV, parvo, CMV, EBV. There are a whole host of other viruses that can cause myocarditis, although I'd say these are the most common ones that we see. In order to make that diagnosis as well, biopsy is the gold standard for the diagnosis. And in the case of a patient who has an arrhythmic event like this or has a dilated heart that doesn't function well, we can also do coronary angiograms at the time of the cath to make sure that there's not an anomalous coronary or some other reason for this. MRI is something that's being used more and more, and Chuck can talk a little bit about that. But with the MRI, we can see areas of edema and inflammation, and so it's becoming more and more widely used to make the diagnosis of myocarditis. The biopsy is limited. Myocarditis can be patchy, and we may miss it with the biopsy, whereas MRI is, now that it's kind of more widely available and there's more expertise in it, I think being more widely used to make that diagnosis. So for this patient, he was initially treated with milrinone and evaluated for heart transplant, but he tolerated conversion to oral heart failure medications. No viral cause was found, so he's now classified as an idiopathic dilated cardiomyopathy. We have no identifiable etiology. Some of his family members were screened, and it was not thought to be familial. No one else in the family seemed to be affected. He had an AICD placed for prevention of sudden cardiac death since he had an aborted sudden cardiac death event, presumably, and he continued to have depressed function. He had an AICD placed, and he was able to be discharged from the hospital with oral heart failure medications. He unfortunately later had a progressive decline in function and had a HeartMate 2 ventricular assist device as a bridge to transplant and is now transplanted. But I think this is a story that we hear, I would say at least 3 times in the last 2 or 3 years I've heard of basketball players dropping suddenly, and whether it's a myocarditis or dilated cardiomyopathy or these type of events that we've had several aborted sudden cardiac death events here in Minnesota that have come to us. So I'm going to go through and talk about the different types of cardiomyopathy. So that was a case presentation of a dilated cardiomyopathy patient. I could tell you some similar stories of hypertrophic cardiomyopathy patients that have an event where they have an arrhythmic event. But we'll go through and talk about the different types of cardiomyopathy and give you a better understanding of those different types. So when we talk about cardiomyopathy, it's a disease of the myocardium that's associated with cardiac dysfunction. There are different types. It can be classified either as a primary disease of the myocardium or as secondary forms. There are forms that are associated with anthracycline or with chemotherapies, hypertensive, inflammatory, metabolic, ischemic. There's a whole different variety of ways to classify it. The other way that you can classify it is by phenotype, and I think this is the more commonly way that we classify it as dilated cardiomyopathy, hypertrophic, restrictive, arrhythmogenic right ventricular cardiomyopathy, LV noncompaction, or other unclassified types. I'm going to focus on the 3 that I think are more commonly seen or that were listed as causes of sudden cardiac death, so dilated, hypertrophic, and ARVC, and not focus on the other ones just because they're less commonly seen. The problem with these is that the etiology does not always equal phenotype, so it makes this classification difficult. So we might have a hypertrophic cardiomyopathy patient who has a restrictive physiology, or we have different phenotypes with the same etiology. In pediatrics, there's a report from the Pediatric Cardiomyopathy Registry that looked at over 3,000 children registered in the database. The overall incidence of cardiomyopathy they found to be about 1 per 100,000 children. and only 1/3 of those have a known etiology at the time of diagnosis. Specifically, we're going to talk about dilated cardiomyopathy. So this form, you have dilation with impaired systolic function. This is the most common form that we see in children. So about 50% of the cardiomyopathies in children, with an incidence of about 0.6 per 100,000 children. Associated etiologies in children, so infectious etiologies, and I think I have a list that talks about those. Familial, so about 1/3 to maybe a half of the cases of dilated cardiomyopathy we're now finding are familial. And this is where it's important to screen family members, and we'll talk about the screening recommendations for family members a little bit later on. Mitochondrial disorders, metabolic disorders, arrhythmic. Occasionally we have patients that have a primary rhythm problem, and treating the rhythm problem may fix the cardiomyopathy and they eventually regain function. I think there was one within the last 2 years that was a junctional PJRT, so permanent junctional reciprocating tachycardia, that Dr. Juraskar ablated. He had an ejection fraction of about 10% when he showed up. He ablated, and over time, over about a year, has regained close to normal function. Inflammatory causes, so whether it's viral myocarditis with direct viral infection of the myocardium or an immunologic response to viral infection, this probably represents about 30 to 40% of cases. So not necessarily the acute myocarditis phase, but later down the line from inflammatory response and then scarring in the myocardium that they can develop a dilated cardiomyopathy late after a viral myocarditis. And then, as we said, idiopathic causes. So how do these kids present? In older kids, I would think of this as patients that have exercise intolerance, dyspnea on exertion, tachycardia, palpitations, chest pain, syncope or near syncope. And unfortunately, sometimes these kids present with a cardiovascular collapse or a sudden death event. Infants more likely to present with respiratory distress, poor feeding, and failure to thrive. The clinical findings, so on physical exam, patients may have tachypnea, tachycardia, hepatomegaly. They may have edema. If they have significantly depressed function, they typically have a gallop rhythm with an S3. And they may have a murmur of mitral regurgitation if they're significantly dilated. Their chest X-ray typically will show cardiomegaly, and pulmonary venous congestion may have pleural effusions if they're more severe. EKG in these patients is usually fairly nonspecific and may just show sinus tachycardia. Nonspecific ST and T wave changes may show LVH or RVH. And arrhythmias, if you Holter these patients, about 50% will have arrhythmias on Holter at the time of presentation, and those arrhythmias being atrial fibrillation or flutter, PVCs, or non-sustained VTAC. And we look at the echo in these patients, so they will have a dilated left ventricle with global systolic LV dysfunction. They may have a pericardial effusion. Sometimes in patients that have severely depressed function, they may have intracardiac thrombi just because blood kind of swirls in the ventricle. I'll show you an echo in a minute. Mitral regurgitation. And also with the echo, we can rule out coronary abnormalities or structural causes of depressed function. Hopefully this plays. So this, the picture on the left is a 4-chamber view, so right atrium, right ventricle, left atrium, left ventricle. And what you'll see is that there's really almost just kind of a rock of the left ventricle. There's it should be a good squeeze function where we see the ventricular walls squeeze in. This is a short axis view, and this is the left ventricle here. There's a pleural effusion back here. But you can see here that this ventricle just kind of rocks. There's not a good squeeze motion to it. This is a pretty severe case of dilated cardiomyopathy. As I mentioned, cardiac catheterization, we can do this for a biopsy if we're looking for myocarditis. Infiltrative or mitochondrial disorders, certain protein defects, we can do some special staining looking on biopsy. Occasionally, if we can't see the coronary arteries on echo, that we might do coronary angiograms as well to make sure that there's not an anomalous coronary artery. And if these patients are proceeding to transplant, we also do cath to look at their pulmonary resistance, calculate the cardiac output, and look at their anatomy. These next two slides are a comprehensive list of different causes of dilated cardiomyopathy. And as you can see, there's a wide variety of things. And so when these patients present, we think about myocarditis and we send a lot of viral studies, but there are other things depending on the personal history with the patient that we look for. There are familial forms, and there are some specific familial forms that we look for, infectious causes, metabolic and nutritional causes, neuromuscular disorders. There, particularly with Duchenne or Becker's muscular dystrophy patients, they can have a cardiomyopathy associated with those. There are toxic causes, and then there are other systemic disorders that also can have a cardiomyopathy. I would say lupus, the more common one that I've seen here, that we've seen a couple of lupus patients that have a cardiomyopathy associated with their lupus. So when we talk about treatment for these patients, if there's a treatable cause that we find in that huge list, then obviously we treat that. If we can't find a treatable cause, then it's supportive treatment for controlling their heart failure symptoms. Anticoagulation is something that's controversial. If they've had a previous thromboembolic event, if they have atrial fibrillation, or if they have a new left ventricular thrombus, then Coumadin may be indicated. Thrombolytic therapy, as far as TPA, if there's a new ventricular thrombus, to decrease the risk of thromboembolic events. Aspirin is also controversial. It depends on the degree of dysfunction, but in theory, to try and prevent clotting within the left ventricle. And then the other thing that's fairly controversial in these patients is the use of AICD, or implantable defibrillators. If there's extrapolation from adult studies that say if the ejection fraction is less than 30 to 35%, AICD may be beneficial. However, in some single institution studies looking at AICD use in pediatric cardiomyopathy patients, that doesn't seem to hold true. It doesn't seem to be prevent sudden cardiac death events, or that the risk of sudden cardiac death event in pediatric patients is different than adults. And AICDs, if there's a history of symptomatic or life-threatening arrhythmias, that maybe those are the cases where it's warranted to try and prevent a sudden cardiac death event in that patient. Predictors of outcomes. So there are predictors of better outcome if they have improvement in shortening fraction over the first 1 to 6 months, and if there was myocarditis at presentation. Worse outcomes is if there was a spherical shape of the LV, so if it's more dilated. Familial cases, if they have elevated diastolic pressures at presentation, presence of ventricular arrhythmias, persistent cardiomegaly or persistent heart failure symptoms, that those patients likely have a more severe case and have a worse outcome. The natural history looking at these, they're from the Pediatric Cardiomyopathy Registry. This looked at 1,800 dilated cardiomyopathy patients over a 20-year period, and they looked at the 5-year incidence rates for various outcomes. Heart transplantation, about 30% of the patients actually progress and go on to heart transplant. Non-sudden cardiac death, meaning patients had progressive heart failure or progressive decline in cardiac function and had a cardiac death, 12%, death from unknown causes, 4%, and then sudden cardiac death, about 2%. So even in patients who had known cardiomyopathy, still a sudden death risk in those patients. And when they looked at this, the risk factors for sudden death, or for sudden cardiac death, seemed to be heart failure at the time of diagnosis, antiarrhythmic therapy within 1 month of diagnosis, so presumably these are patients that had more rhythm problems, and then a family history of sudden cardiac death or dilated cardiomyopathy was not associated with sudden cardiac death in these patients. So the family history didn't seem to matter as much for their ongoing risk of sudden cardiac death. This is a list of the genes. So when we talk about genetic screening or genetic causes, this is a list of genes that have been identified to be associated with dilated cardiomyopathy. The most of any one of these for dilated cardiomyopathy is maybe 5 to 7% of cases. And there are a significant number of cases where we do not find a genetic cause, even if it looks like it's a familial case. So with the current commercially available gene panels, they have a sensitivity of about 50 to 60% for dilated cardiomyopathy to find a gene mutation. So they're not great. And I'll talk a little bit about the specifics of who should get tested at the end. We'll shift a little bit and talk about hypertrophic cardiomyopathy. So in this case, we're talking about increased left ventricular and sometimes right ventricular wall thickness in the absence of hypertension or valvular heart disease. This has a prevalence of about 1 in 500 adults. Typically involves the septum, but the LV free wall and the apex can be involved. In these patients, the LV volume is normal to decreased, and they frequently have diastolic dysfunction. They can have LV outflow tract obstruction, and we'll talk about the risk of sudden death in those patients. And that occurs in about 1/4 of patients when they present. I would say many of these patients are asymptomatic and are picked up on family screening. I think this is more common, that there's a better understanding in the public that, oh, someone in the family got diagnosed with hypertrophic cardiomyopathy, everybody needs to be screened. I think dilated cardiomyopathy, or those patients, it's less common that those are referred for family screening. Some of these may be evaluated for murmur and have LV outflow tract obstruction, and some may have heart failure symptoms. So similar to what we talked about with dilated cardiomyopathy, but dyspnea on exertion, chest pain, presyncope and syncope, palpitations, fatigue. The symptoms in these patients can be due to several mechanisms. They may have LV outflow tract obstruction at rest. They may have LV outflow tract obstruction that's only with exercise. They may have decreased cardiac function in the absence of obstruction, arrhythmias, or may have diastolic dysfunction because of how thick these ventricles are. The exam is typically normal in asymptomatic patients that are picked up on screening. They may have an ejection murmur if they have outflow tract obstruction, and there's certain maneuvers you can do that can try and increase or decrease the intensity of that murmur to try and determine if that's what it is. They usually have an increased LV impulse. EKG is typically pretty classic in these patients, so there are increased LV voltages. They may have ST and T wave changes. So in this EKG, there are diffuse ST and T wave inversions and T wave or ST segment depressions. They can have left atrial or biatrial enlargement and left axis deviation. Biopsy in these patients can be diagnostic. So on the right is a normal endomyocardial biopsy. So what you see is that the myocardial fibers line up nicely, and the classic finding in hypertrophic cardiomyopathy is that there's what we call myocyte disarray or myocardial fiber disarray. So rather than the muscle fibers lining up nicely, they're kind of in every which direction, and that's partly why they have diastolic dysfunction, is that the myocardial fibers are not lined up. These are echo images. Both of these you can see. This one is showing left atrium and the left ventricle. You can see how markedly thick and how small the left ventricular cavity is in this one. And then this is a slightly different view, but again, left atrium and left ventricle. And we can see how markedly thick the left ventricle is and how small the left ventricular cavity is. As far as etiology in these, there now reports probably up to 75% or so are caused by mutations in specific contractile protein genes, most commonly the beta myosin heavy chain, and then there's a cardiac myosin binding protein C. And there are multiple different gene defects within those genes that can lead to hypertrophic cardiomyopathy. It's typically autosomal dominant, but with variable penetrance, and so it's where family screening can be difficult. The natural history in this type of cardiomyopathy, the mortality is reported to be maybe as high as 2% per year in adults and 4 to 6% per year in children, with the major causes of mortality being sudden cardiac death, heart failure, and stroke. When they look at these patients, their significant outflow tract obstruction at rest is an independent risk factor for mortality. There are age-related increases in arrhythmias. And when we look at postmortem studies on young athletes with sudden cardiac death, as I talked about before, hypertrophic cardiomyopathy being the most common, with certain studies up to 36% of sudden cardiac death in athletes. So the treatment goals in this are really to reduce the risk of sudden cardiac death. There are certain high-risk factors for arrhythmia or for sudden death, such as family history of sudden death, syncope, non-sustained VTAC, an abnormal blood pressure response to exercise, or massive LVH, what they consider an LV wall thickness greater than 3 centimeters. And then there are things that are considered possible risk factors for sudden death, so earlier age at diagnosis, LV outflow gradient, the degree of LV outflow gradient, diastolic dysfunction, if they have evidence of myocardial ischemia. And then there are some discussion that there are specific genotypes, so troponin T and certain beta myosin defects that may be at a higher risk of having sudden cardiac death. When we look at treatment options for these patients, AICD primarily for prevention of sudden cardiac death, surgical myectomy or alcohol ablation if there's significant outflow obstruction, and transplant as one option, or kind of the end option if none of those other therapies are successful. There's a comprehensive guideline statement about the diagnosis and treatment of hypertrophic cardiomyopathy from the American Heart Association. This really nicely details specific recommendations as far as screening and making the diagnosis and what the treatment recommendations are, but it's like a 70-page document. But if you have a patient with hypertrophic cardiomyopathy and want to learn more about it, I think this is a nice summary guidelines. This is from that guidelines paper. I think I don't know that you'll be able to see it very well, but I think this is why this is complicated. So if you make the diagnosis of hypertrophic cardiomyopathy in a patient, it's kind of where you start at the top here. Depends on whether or not they have obstructive physiology or not as to where you go with their therapy, but there are different therapies that are options. And this doesn't even talk about AICDs or prevention of sudden cardiac death. This is just talking about therapies for their heart failure within hypertrophic cardiomyopathy. The one big thing that they focus on is, as I said, prevention of sudden cardiac death, and that's really where we started this talk from, is how do we do that? So for hypertrophic cardiomyopathy, there are risk stratifications, and there are recommendations that they make for this. So basically, all patients with hypertrophic cardiomyopathy should undergo comprehensive sudden cardiac death risk stratification at initial evaluation to determine the presence of the following. So these would be considered high-risk things I think we talked about earlier, but this lays it out a little bit differently. But personal history of ventricular fibrillation, sustained VTAC, or sudden cardiac death events, family history of sudden cardiac death events, unexplained syncope, documented non-sustained VTAC, and maximal wall thickness greater than or equal to 30 millimeters. And then there are class 2A and 2B recommendations, so other things that maybe put them at a higher risk of sudden cardiac death. And what's important then is to know which of those patients then need to have AICD placed to try and prevent their sudden cardiac death. This is a similar thing that I think is a little bit easier to read, but from the European Society of Cardiology. So they had similar guideline statement that they did. Class 1 recommendations and the class 2A being likely AICD placement would benefit in these patients. The class 2B or class 3 that there is probably not enough evidence to support AICD use in these patients. But I think it's similar to what we talked about earlier. I think this one just lays it out that it's a little bit easier to see or to reference back to. When we talk about genetics in hypertrophic cardiomyopathy, I think that there are less genetic causes of this that we've found or narrowed it down to fewer genes that we look at and that are more likely causative in these patients. So when you look at the frequency of familial cases that have these gene defects, I think that there are, located primarily on this beta myosin, heavy chain or myosin binding protein C, 30 to 40% of the cases that are familial will be linked to those genes. However, there are quite a few sporadic cases that are also linked to those genes, but at least we know what genes to go look for. And then the last type of cardiomyopathy I'll talk about, because I think this is something that's this diagnosis being made more commonly now. It's a specific, so ARVC, or arrhythmogenic right ventricular cardiomyopathy. This is a specific disease of the myocardium that's associated with arrhythmias, predominantly the myocardium of the right ventricular free wall, and that's replaced by fibrous or fatty fibrous tissue. They typically have abnormal RV function with RV free wall hypokinesis or dyskinesis. This can be a difficult diagnosis to make based on echocardiogram, and I'll talk about that in a minute. But the prevalence of this may be as high as 1 in 1,000 in the general population. Clinical presentation, typically arrhythmia of an RV origin or sudden cardiac death is one of the most common presenting things. Most commonly present anywhere between the ages of 10 and 50 with a mean age of diagnosis of 30. And as I said, the presenting symptoms, palpitations, syncope, chest pain, dyspnea, or RV failure. And there's one study that reports this as high as 11% of sudden cardiac death in young adults and 22% in athletes. So this is something that we need to be thinking about as well. Echo, you can see RV dilation and may see some degree of RV dysfunction, although I don't think any of the echo folks would say that we're great at assessing the RV free wall very well, particularly in older patients where they may not have the best windows to look at that. EKG, they may have PVCs or ventricular tachycardia that are increased with exercise and associated with an RV focus, so they have a left bundle branch pattern, QRS prolongation. And cardiac MRI is really how to make this diagnosis. So there can be global and regional dilation and dysfunction of the right ventricle, but really you see intramyocardial fat and late gadolinium enhancement, and that's how they make this diagnosis. They see this fat deposits in the RV free wall. Biopsy is not very specific or sensitive, so it's not commonly done, again, because when we biopsy, we're biopsying from the interventricular septum, not from the RV free wall, so we could miss this. There are estimates that at least 30% of these are familial, and there can be autosomal dominant and autosomal recessive forms. The autosomal dominant forms have been mapped to many different chromosomes and at least 6 genes, and there are the autosomal recessive forms are mapped to about 2 different genes currently. These patients are at risk for sudden cardiac death, especially with exercise, and so these patients are typically limited from strenuous activities. If they have progressive RV or BIV failure, then they go through standard heart failure treatment. And AICD, as far as prevention of sudden cardiac death, in anyone who's had sustained ventricular arrhythmias. And then there's also selected patients who are high risk should get AICD, and it's much less clearly defined for ARVC. There have not been any consensus statement or guidelines that have come out for this, like there are for hypertrophic cardiomyopathy. And this, again, looking at the genes that are associated with it, but again, the familial cases and the frequency of these genes is much smaller. Again, I think this is a diagnosis that is really kind of becoming more in vogue in the last 5 years or so, and so we're not nearly as far into the research aspect of finding the specific causes in this. So who needs to get family screening for cardiomyopathy? I think that's what's important for pediatric residents to understand. Patients should have a detailed 3-generation family history, so go back at least 3 generations to look for any of these red flags. Clinical screening for all first-degree relatives. Once you make the diagnosis in a patient, all first-degree relatives should have clinical screening, which would include history, physical exam, EKG, and echocardiogram. And then genetic testing. So the problem with genetic testing is that, as we talked about, these can be complex or multifactorial inheritance. There may be variable genotype-phenotype correlations. And so the recommendations are that these, if you're going to do genetic testing, it should be performed at centers familiar with genetic testing and counseling because it's a complex process. There is a 2009 Heart Failure Society of America guidelines that do recommend genetic testing for the one most affected person first. And the reason that they recommend that is that then you could potentially do, if you find a gene, that you could then do individualized gene testing for that one gene and hopefully either find at-risk family members who then need to go on to further clinical screening and need to continue with clinical screening even if they don't have the disease at the time of initial clinical screening. Or you may be able to kind of clear some family members and say they aren't at risk because they don't have this gene and they can be cleared from further clinical screening. So within that Heart Failure Society guidelines, they talked about clinical screening for cardiomyopathy and talk about the time intervals that you should screen family members for the different types of cardiomyopathy and depending on the age of the patient. So and this looks at screening interval if a genetic mutation is present or if the gene testing is negative or if they did not do gene testing and goes through the breakdown of how often those patients should be screened. And then at the bottom there it does say at-risk first-degree relatives with any abnormal clinical screening test should be considered for repeat clinical screening at a year, so more frequent follow-up for those patients that have any abnormal findings. And And then this is specifically for hypertrophic cardiomyopathy that talks about family screening for detection of hypertrophic cardiomyopathy in families. Less than 12 years of age, because most of these might present greater than 12 years of age, optional unless there are specific high-risk categories. And then age 12 to 18, or basically when they've gone through physical maturity, every 12 to 18 months. And then greater than 18 at the onset of symptoms, or at least every 5 years. And if there's a malignant clinical course that occurs late in those families, that you may want to see them more frequently. So we'll kind of be getting to the end here, but I want to briefly touch on our Cardiomyopathy Clinic that we now have here. We started at the beginning of this year. Within that clinic, we'll have genetic testing and counseling for familial cardiomyopathy patients. There are several commercially available and research-based gene panels that we use, and so our cardiac genetics and genetic counselor will know which tests to order in each family, and we can do hopefully targeted gene testing and ideally be able to roll out patients that we then don't need to continue to do clinical testing on. We'll offer a family screening program within that so that we can see all family members at one clinic time. For those patients that are familial cardiomyopathy patients, we can see all the kids in one. Or if it's the things that get referred, grandma got diagnosed with a cardiomyopathy and now everybody needs to be screened, we can bring them all in at one time in one clinic. And eventually this will allow us to participate in cardiomyopathy research trials. This picture is a perfect example of why we needed a clinic like this. This family, so Reese is, I think, 7 now. She was the index case in this family. When she was a baby, she presented with heart failure symptoms, was treated, got better through infancy, but because of her, Mom and Dad were screened, and Dad was identified as having a dilated cardiomyopathy. He had an ejection fraction of about 30%, but was asymptomatic, never knew anything was wrong with them. And then their subsequent pregnancies were screened, and Reagan was picked up in utero as having a cardiomyopathy, was fairly sick as a baby, got a little bit better, and then ended up going on to heart transplant when she was 6 months old. So the one thing I think this highlights is that even within a family where presumably they have the same genetic defect, there's a wide variety of clinical phenotype within that family. But it highlights the importance of why we need to screen families and be able to identify then those at-risk individuals and know to watch for signs and symptoms in them. So just to kind of finalize here, so get back to where we started from, how do we achieve the prevention of sudden cardiac death? I think the important thing for general pediatricians is to remember that 12-point AHA pre-participation cardiovascular screening questions. And if there's any positives on it, either perform a screening EKG and send it to a cardiologist to look at, or referral to pediatric cardiology so we can investigate further along those lines. I think understanding who needs familial screening for cardiomyopathy. So if you get a positive on a family history, or seeing a kid for a routine well-child check, has anything changed in the family history, anything that we need to know about, and identify those patients that need to be screened. And then the final piece is there are going to be patients that are missed, that are not picked up on screening, is educating for AED use in the community. So converting these from sudden cardiac death to an aborted sudden cardiac death event because there's AED use or bystander CPR in the community. So, and there's a list of references if anybody wants. I'll take questions.
Great, Becky. Thanks. So we have a few minutes here. Joe?
In family, asymptomatic patients with genetic carrier and a high risk of cardiomyopathy, is there anything other than you do that screen them for the development of the cardiomyopathy, or you use after those and do other things in advance to try to reduce the likelihood of them developing a failure?
So there's not good evidence for that yet. I think there are some indicators that if there is an slight dilation of the left ventricle in a dilated cardiomyopathy patient, for example, that if they have normal function but they're starting to dilate their left ventricle, that we start therapy in those patients then to try and maintain their function normal and try and prevent further dilation of their left ventricle. So yeah, it's ACE inhibitors and beta blockers that we use in those patients. So, Jamie, did you have a question? No? Okay. Lazarus?
Thank you. I have a question. I've seen the briefly these recommendations, and they sound reasonable based on the amount of knowledge that we have and the much more that we don't have. My question was about the particular recommendation to screen family members with an index case with non-compaction cardiomyopathy, which is actually it is a developmental defect, and it should be at the first time that you see the patient. It's not something that will be developed 5 years later, 10 years later, 15 years later. So is that because of the techniques that we use to assist the analysis of multifactorial hypertrophy? Why? I mean, developmentally, everybody who has non-compaction, you have to come to a point.
Yeah, I'm not sure why they included non-compaction in that family screening recommendations, although it did talk about, I agree that they shouldn't have, but there may be variable degrees. There may be a very subtle area that's non-compacted, but they might be at a high risk of arrhythmias or of development of a dilated phenotype later on. There may be overlap of those within the same gene mutation.
Well, it's the only condition that they don't know to have overlap. All the others, hypertrophic, and maybe they can straight.
But there are, within the gene defects that you can have non-compaction cardiomyopathy, you can also have dilated cardiomyopathy that's caused by the same gene defect. And so I think that's where that comes in, is if you identify one of those gene defects that has overlap between both phenotypes.
I think the other problem is that for most of these things, when you find the patient, you know they've got it, but very few of those patients show up having had an echocardiogram earlier in life showing that they had non-compaction before they developed the symptoms. And I think that's the weak point of your argument. Well, they always had it, but you have to have actually seen that they had it before.
The question is why do you need to keep screening them every 5 years?
Yeah, but it's not clear that I don't know of any longitudinal studies showing that they were always abnormal on echocardiogram
Right.
prior to developing symptoms, or that they were, or conversely, that they were normal before and became abnormal later. Yes, I understand you'd think it would always be there, but the actual proof that it's always there, at least I haven't seen a publication showing that. Is there another question? Yes.
I think it's going to be frustrating from a population-based screening perspective when you're talking about young folks and, the risk for a sudden cardiac event while they are doing a healthy activity, in that some kids who are at risk, who, all of your screening protocol, family history is negative. You do an EKG and an echo, and they're normal because it's the ARVC that's in their family. Nobody's ever had it before, and the echo and EKG are going to be normal until someone has their event. So it's almost like the screening that you can do it. I mean, how far can you take the screening? You can't take it too far, but it's not going to capture. It's not going to be a really tight net to capture a lot of people who truly do have it and are at risk.
Although presumably you're, in an ARVC, if they're a more severely affected ARVC, a screening EKG may be abnormal. And if it's someone who says, I have symptoms when I exercise, then we exercise them and we should be able to make that diagnosis. And then it's, screening family members from there. But yeah, I agree. The index case, there are going to be those, and that's why I said AED use and having AEDs widely distributed in the community and having people know how to use those is still important.
Speculate on why there's a wide degree of expression differences even within the same family,
I don't think it's well understood, and I think that maybe there's multifactorial factors. It's not just the genotype, but it's other things that happen within that individual patient that cause that variable expression. But I think we see it in all different forms of cardiomyopathy. It's not just the dilateds that we have that wide variety of phenotype. I think non-compaction in particular, where we pick it up in a baby who's extremely ill and there are asymptomatic adults in the family. And I think hypertrophic cardiomyopathy as well, that there's a very wide phenotype within the same genotype in families. Yep, Jamie.
Do you have any recommendations for medical therapy for patients with hypertrophic cardiomyopathy, shortage, supplementation, or?
I think that I think the guideline statement really kind of went through, and there was, level of evidence data because it looked at a large number of patients and it was a consensus statement from kind of the experts in the field, and it did give a nice clinical breakdown of what their EF is, what their diastolic pressure is, whether or not they have symptoms, and it looked at multiple therapies. I think it included beta blockers, verapamil, ACE inhibitors, and it didn't specifically comment on AICD therapy, but it did look at alcohol ablation or septal myectomy. So it did break down all of those specific recommendations, and I think that that's the best evidence that we have or what we can use at this point for those patients.
Yeah, obviously, treating the septum only works in those patients who have outflow obstruction and doesn't reduce the risk of sudden death from an arrhythmia.
Right.
Or
So
it doesn't eliminate it.
I mean, the
Pardon.
patients that are, that have an ongoing troponin leak and have ventricular arrhythmias anytime they do minimal things, I think those are high-risk patients that, transplant may be the best option for them.
Yeah, I think it's the other end of the spectrum. It's the spectrum that has maybe obese, hypertensive, on and off, obstructive
Yeah.
acceleration of flow, and you want to manage risk factors in those patients, but they need therapy too.
So I think that's where that guideline, that figure I put up there is nice because it does kind of lay out some of those different pieces.
Great.
Right.
Well, Becky,
Thanks.
thanks a lot. Very nice.
Thanks.